thank you very much. It's a pleasure for me to be here. This is the first time I've actually spoken at a surgical meeting, and it's nice to see some old friends, and nice to take such a short plane ride. I just came over from Phoenix, so it was relatively easy for me. On the schedule, it says I'm going to talk about adenocarcinoma in situ. In fact, I'm going to broaden that a little bit and talk about the new classification of adenocarcinoma, because it's within that context that the concept of adenocarcinoma in situ came along. I have no financial disclosures, and supposedly now when you give a CME talk, you're supposed to start off with a case presentation, because that's what people will remember. And I suspect all of you all right now struggle with this situation. What do you do with a small adenocarcinoma, ground glass opacity radiologically? And you may be lucky enough to have a biopsy that tells you there's a lipidic growth pattern, and that's the key pathologic word these days. Lipidic, meaning that the tumor cells are growing along the alveolar walls. And I'm not going to ask you to put a show of hands up, but some would consider lobectomy, some wouldn't. And as you heard from the prior talk, what do you do if there's several other ones of these lesions? And I don't have an answer to that, but I think that is, as mentioned earlier, is the conundrum that we, and particularly you, are facing. Well, my task is to really introduce this International Association for the Study of Lung Cancer and several other groups reclassification of adenocarcinoma. And you can see that with the list of authors there that includes some thoracic surgeons, this is quite an undertaking. And the chief author there, Bill Travis, is a guy who loves to put together these big international consensus things. This was a core panel that included everybody that deals with lung cancer, including thoracic surgeons. As is wont these days, they did a huge literature review and looked at over 11,000 citations. They reviewed 312 articles. The rationale was to bring the classification of adenocarcinoma to the 21st century. And here they are at one of their meetings. I believe that's New York. And notice that this is a concise review. The encyclopedic review probably will come out later. It's a concise review of 41 pages. If you know Bill Travis, you know why it's 41 pages. It probably would have been 80 to begin with. But at any rate, there was a group of distinguished physicians, all familiar with cancer, that got together to reclassify adenocarcinoma for us. This was primarily a pathologist-driven group, so pathology sort of bubbled to the top of a lot of what went on here. My outline for this lecture is to talk a little bit about the changes in this classification, talk about some of the evidence for those changes, and then really to say, what are the implications for you all as the people that have to deal with these patients surgically? From my point of view as a pathologist, and that may or may not be correct. Now, if we go back to the adenocarcinoma classification of 2004, which is currently the official WHO classification, although it's superseded by this 2011 classification, this was the grouping we had for when we had a carcinoma under the microscope, an adenocarcinoma, what were we supposed to call it? And those are the names. We have a longer list now, but notice that it's divided into two categories, pre-invasive lesions and invasive lesions. The major change is right here, the concept of adenocarcinoma in situ and the concept of minimally invasive adenocarcinoma. And that's the key change in this classification. Now, the other names down here at the bottom have changed a little bit in the invasive adenocarcinoma group, but they're pretty similar to what we've been dealing with in the past. They've just been renamed a little bit and regrouped a little bit. The key concept is that some of the things we used to call BAC, as mentioned by the prior speaker, are now called adenocarcinoma in situ, and then there's a group that we may be able to segregate out the minimally invasive adenocarcinomas, and I think that's the key here, the key new change in this classification. So I'll show you some examples, and you can see at Mayo we still have state-of-the-art scopes that we deal with, so we're able to see these carcinomas very well. Here is a case. This is a ground glass opacity with neoplastic cells growing on alveolar walls. In 2004, that's a BAC. We take the same tumor. In 2011, new adenocarcinoma classification. That tumor is now called adenocarcinoma in situ. Here's another one, and notice I put a 0.5 cm bar there, a 5 millimeter bar. There's an area of invasion right here, and those are some invasive cancer cells, that is less than ½ a centimeter. In 2004, we would call that adenocarcinoma mixed subtype. It includes some BAC regions, it included some invasive regions, so that it was in the mixed subtype in 2004. The same tumor exactly the same tumor, now is minimally invasive adenocarcinoma. It's smaller than 3 cm. It has invasion less than 5 millimeters. And I'll show you in a minute why it's important that we at least try to stratify these adenocarcinomas. Now, it's imperfect. It's not so easy to measure the size of the area of invasion, but let us worry about that. Let's just get the concept that we can stratify these into prognostically significant groups. Now, prior to 1999, that exact same tumor would have been called by most people BAC. And you get the idea that BAC has been used for all sorts of different tumors, and that's one of the reasons there's been this push to drop the term BAC, bronchoalveolar carcinoma. Let's look at another tumor. This is a bigger tumor now. There's the 0.5 cm bar. This is a bigger tumor. It's got a larger area of invasion here, but it includes some lipidic growth or BAC type growth. It includes some acinar invasive growth. In 2004, that would be a mixed subtype adenocarcinoma. And one of the problems, by the way, with this 2004 classification is that 90% of the cases were mixed subtype. So if you have a classification that stratifies things that way, it's not very useful. Same tumor, 2011, has a lipidic component, as you see here, has an acinar component. This tumor is now a lipidic predominant adenocarcinoma, and as we'll see, there's some significance to recognizing the predominant growth pattern of an invasive adenocarcinoma. That same tumor, prior to 1999, would have been called by many BAC. Yeah, the tumors are all the same. You know, we have this thing in medicine, the diseases don't change, we just change how we look at them. We've changed the names of some of these, that's true. But the reason for that is prognostic subgroups have been defined among lung adenocarcinomas. And your job then, as the guys who, where the buck stops with the thoracic surgeon on these lesions, should this translate into a different management strategy for the subgroups? It's easy for pathologists and radiologists to say these are favorable features, but the patient isn't going to come back to us when that tumor recurs. The patient's going to come back to you all. Here is some data from Bill Travis at Memorial showing that if you use this sort of a classification, your AIS, MIA, and lipidic predominant tumors have a very favorable prognosis up top here. There's an intermediate group that can be recognized, and there's a poor prognosis group based on those patterns that I showed you previously. So there is, and there's some other data that have come out more recently. This is from about 3 years ago. There is some reason to stratify adenocarcinomas into subtypes. So what I think is important for thoracic surgeons, number one, new nomenclature, BAC, has been dropped as a term from our lexicon. We're all going to think about it because it's so ingrained, but the concept has changed because it was used for so many different lesions. So BAC was first described in 1960. Lebo has been described as the one who described it, and that's about where I came into the picture there, you know, about 1970. So when I first came along, BAC included all sorts of things. It included papillary adenocarcinoma, which we take away now. It included some invasive cancers. It included a micropapillary pattern, which we'll talk about. And all those things that have central sclerosis that we now recognize as invasion have all been taken away. So we have a much smaller group, but a much more homogeneous subgroup now that we're calling adenocarcinoma in situ. And I'll come back to why that concept is important in a minute, but short answer is these are being picked up by screening. All of these patterns in the past were originally included under BAC. Here is a papillary adenocarcinoma. Data showed that these were worse actors than BAC. That was segregated out as a different tumor. Papillary adenocarcinomas, according to pathologists, have a central fibrobascular core, whereas a micropapillary pattern are just these little clusters of cells floating around. And it turns out that a micropapillary pattern, as you see here, is a bad actor. It likes to get in lymphatics, and there's lymphatic invasion there where you see the arrows. And there it is in the lymph node, showing the same little clusters of tumor cells. A micropapillary pattern is seen in 40 to 50% of lung cancers, at least as a minor change, and its presence confirms about a 20 or 30% drop in prognosis. Significant finding then of micropapillary pattern. And the decreased survival is thought to be related to an increased metastatic potential. And here are 4 studies They all show that a micropapillary pattern confirms a worse prognosis, and that is actually independent of node status, as shown in one of those studies. So there is reason for pathologists to subdivide these adenocarcinomas because we can stratify them into prognostic groups. Now here's a case from the 1970s that I have in my collection as an example of BAC, bronchial-alveolar carcinoma, and I used to show pictures like this and say, well, there are the little tumor cells showing their erogenous spread floating around in the alveoli, and all those of you that have some gray hair know that term erogenous spread. Well, in fact, that's the micropapillary pattern. That's a bad pattern. This is no longer included as adenocarcinoma in situ. Then we get to the issue of the kinds of BAC that we're taught about, have been taught about. There's the non-mucinous one that's typically a solitary ground glass opacity, as you see here. There's the mucinous one. Patients tend to cough up a lot of mucus, and they have the lobar consolidation by the mucoid tumor. It turns out that those are completely different. They're grossly different. They're radiologically different. There's a significant prognostic difference, and there's immunohistochemical and molecular differences. So I think moving forward, there's good reason for us not to consider mucinous BAC and non-mucinous BAC as we've been taught. They're completely different tumors. And as mentioned, we shouldn't even be using the term BAC. Here is one that in the past would have been called a mucinous BAC, and we've all seen these lovely pictures of these mucin-producing cells growing on alveolar walls, making lots and lots of mucus around them. Here's another case showing those same tumor cells, and it turns out when we study these tumors carefully, there's almost always some invasion there. So what used to be called mucinous BAC is now, for the most part, called invasive mucinous adenocarcinoma. So the next couple of things that I think it's important from this new classification, mucinous and non-mucinous BAC are completely unrelated tumors, and as mentioned, BAC is not a term we should be using. And there are prognostic subsets of adenocarcinoma, adenocarcinoma in situ, minimally invasive adenocarcinoma, and then the groups with the poorer prognosis, such as micropapillary. Well, let's take a little reality check. The main point of this lecture is that not all adenocarcinomas are created equal. Most of this change in classification has to do with small cancers, 2 to 3 cm and smaller, and of lung cancer, they're less than 5% of all lung cancers. But why is it important to talk about to a group like you? Well, they're going to be a much higher percentage of the cases coming to thoracic surgeons for resection. Can't give you a percentage, it could be 20 or 30% of the patients that come to your door, and the radiologists are finding these much more frequently. So I think we need to understand this subset, that in the whole world of lung cancer, they're pretty rare, but in the subset that we're looking at, they could be a much higher frequency. This 2011 classification was done by pathologists, so naturally the recommendations and considerations that have come out of it are going to put pathology at the top, and there's a long list of those, and I'm not going to ask you to read those. I will highlight a couple of them. Most of them I've actually already talked about. Most of these are a strong recommendation with a low quality of evidence, and you know it's in vogue these days to talk about quality of evidence and strength of recommendation. When somebody says low quality evidence, that sounds suspiciously like expert opinion. Now there is a little bit of data there that supports this, but I would keep this classification in perspective. It's not like there's a lot of hard, strong data out there that supports it, but I go along with it, and I think as a concept it's valid. And one thing that if you are getting a pathology report that still talks about non-small cell lung cancer not otherwise specified, you need to have your pathologist educated that we're doing more than that now. We're subdividing non-small cell lung cancer into significant groups, squamous differentiation, adenodifferentiation, these small tumors that I've been talking about. Well, the clinical recommendations from this 2011 classification are really just one. EGFR analysis should be performed in all patients with advanced disease. I will point out that an additional clinical consideration came up. Biopsy methods should allow for adequate tissue for molecular testing. Half of lung cancer is diagnosed cytologically. That's not a lot of material. So I think it's incumbent upon us as pathologists, since we're dealing with smaller and smaller specimens, to make sure that we are preserving as much tissue as possible. And that's a conversation you could have with your pathologist. Are they making sure that there's tissue around to do these studies? And what we've recently talked about in, say, a needle biopsy of the lung is if there's tumor in that needle core biopsy, we can divide that in half and use just half of that block for all our, quote, special stains and save the rest for further analysis. And exactly how we triage tissue, which is a rare commodity in some cases because there's not very much, we need to be very careful with that. In terms of looking at lung cancer, we've talked about prognostic markers, or we, the medical community, has talked about prognostic markers, and now we're getting into predictive markers. What is a prognostic marker? Stage, that's one example. Lymph node involvement, all that sort of thing. Those are prognostic markers. There are many biomarkers that are both prognostic and predictive. Predictive markers are those that provide information that change how you manage a patient. Pathologists have dealt with prognostic markers for years. We are now assessing predictive markers in the tissue that you give us, and the best known one, of course, is EGFR mutations. And this is the name of the game. Some of you probably heard the article from the New England Journal in the past couple of days that tumors have sufficient heterogeneity that maybe getting EGFR receptor from one part of a tumor may not show the same change as another part of a tumor. That's, I think, a challenge that we'll need to deal with going forth. But for right now, the rule is if you have advanced stage lung cancer, particularly adenocarcinoma, you want to know the EGFR status. Another interesting thing that's come along is tumors, adenocarcinomas that have signet ring cell change, and that's where the tumor cells look kind of like a signet ring with the nucleus pushed off to the side. Those are often a clue to EML4 ALK mutations, one of the less common mutations in lung cancer, but no less significant, but because there is some specific therapy that can be tried in those cases. The molecular recommendations are no big surprise from this series. The molecular biologists involved in this reclassification said more study of this, more study of that. They need more data. Now, have you ever heard of a scientist that said they had enough data? I think we're always in that position, and we always need more data. But we have enough data, I think, to suggest that molecular study of lung cancer is where we should be right now. So what I think is important for thoracic surgeons from this classification, histology may predict molecular subtypes. Molecular testing, especially in patients with advanced disease, should be done. And at our place in Scottsdale, I'm at Mayo Clinic in Scottsdale, we're kind of a small shop, and we have one primary lung oncologist and a couple of others. And we've just sat down and gone through an algorithm of how we're going to do testing, and most places have that now, particularly academic centers. And we do more than EGFR. We have some things called reflex testing, where if EGFR is negative, we're going to go to the EML4 ALK and then to some other things, depending on the clinical setting. But we're doing it in all cancers, including resected low-stage cancers. Now, the surgical considerations that were put forth in this 2011 document are a little bit beyond my ability as a pathologist to address, but I think some of you, probably many of you, are familiar with this. Is sublobar or limited resection adequate for some early lung adenocarcinomas? And I'm sure you've struggled with this, and probably some of the treatment trial talk yesterday dealt with that. Can CT be used to select patients for something less than a lobectomy? Is there a difference in outcome between VATS and traditional thoracotomy for early stage adenocarcinoma? What can be expected from pathologists at frozen section? Should a systematic lymph node dissection be performed? How should multiple lesions be addressed? And the prior speaker mentioned the issue of multiple lesions. Well, I'm a pathologist, and I can't address most of these 6 things, but I can tell you, you need to be careful with your pathologist. Doing frozen sections on small adenocarcinoma is hard. It's hard. I'm supposed to know what I'm seeing in these things, and it's hard. And I think you're going to find your pathologist undercalling cases. It's a lot easier to go back and take a lobe out than it is to go back and put the lobe in. So you might find your pathologist struggling with these. Just be aware of that, and they've got to give it their best shot. They're going to be wrong sometimes, but it is a difficult area. Looking at CT scan, there's a lot of data, particularly from Japan, about ground glass opacity and prognosis, and lesions that have a lot of ground glass opacity have a significantly better prognosis. This is just one of a number of studies that's out there. There's similar findings from pathology that if a lesion is predominantly lipidic, as you see here in the top, or only focally lipidic and mainly a solid mass, there's a difference in prognosis. In a pathologic study looking at those showed 100% survival for those that had favorable factors, which were lipidic growth pattern and small amount of scarring associated with the tumor. And I've given you some of this data. This is some of the background data in this classification. Ground glass opacity, lipidic growth pattern have a favorable effect in terms of prognosis when they're the predominant change in a lesion. So given the available data, this was suggested 6 or 8 years ago, would you consider limited resection for something that's small, say 2 cm in diameter or smaller, or with a lot of ground glass opacity with less than ½ centimeter fibrosis? And that's not something I can answer, and that's something that I hope that you all will answer for us. And I think there is a trial going on and probably some new trials that are going to look into that. This is some non-prospective, non-randomized data from a study in Japan that showed no difference between the sublobar and the lobar resection group for these cases, but note that this is not a randomized trial. So the surgery recommendations that came out of this 2011 adenocarcinoma was the role of limited resection as yet to be determined because of the lack of randomized trials. The extent of lymph node dissection is controversial. The accuracy of frozen sections assessing the presence of invasive adenocarcinoma needs further investigation and specific guidelines for frozen section sample. The guidelines are look hard because, as I said, it's difficult. And the treatment of multiple lesions needs to be standardized. And hopefully this is the group that's going to deal with some of these questions. I can't do it. I can kind of lay it out there. I'm sure these issues are familiar to all of you. So my final recommendation then, what I think is important for thoracic surgeons, there may be a subset of patients, at least from my point of view as a pathologist, that sublobar resection would and could be appropriate. And I will end there with a picture from Tour de France about 1900. Things have changed, haven't they? Thank you very much.